Good morning and welcome to Urology Grand Rounds, which is a two-session program to highlight some of the advances that are occurring in prostate cancer. And as many of you in the audience remember, we had a session previously on localized prostate cancer. And now today we're going to talk about advanced prostate cancer, and also a little bit about the research that we're doing in our environment here. And when we talk about our environment, we're talking about several locations and organizations. We're talking about the University of Washington School of Medicine and Medical Center. We're talking about the Fred Hutchinson Cancer Research Center. And we're also talking about the Seattle Cancer Care Alliance, or so-called SCCA, which is an organization which brings together the expertise from these two institutions and also from our Children's Hospital in order to bring the expertise closer together to make discoveries faster and make patient care better. And for those of you in our TV audience, we're talking about several locations. We're talking about the Fred Hutch Cancer Research Center located on our Lake Union. And as many of the audience know, this is a world-renowned center for research in prostate cancer. We're also talking about the University of Washington Medical Center, which is equally renowned for patient care and for biological research. And when it comes to prostate cancer, we're talking about two prostate cancer multidisciplinary clinics for patient care and clinical trials. And when we're talking about these two centers, we're talking about the SCCA building headed by Dr. Tia Agano. And in that clinic, they deal with more advanced prostate cancer and more innovative early clinical trials. Whereas at the SCCA Prostate Center at the university, headed by Dr. Bruce Montgomery, we're talking about earlier prostate cancer disease and certain selected advanced disease trials. And you'll be hearing from both of these medical oncologists and experts in prostate cancer today at this session. But at both of these places, we emphasize a multidisciplinary approach to prostate cancer, which we feel is essential for good patient care and for faster innovation. And we're also going to talk today a little bit about some of the research that's occurring in our environment. We can't talk about all of the various people and subjects of this research, including animal models, immune therapy, biochemistry, molecular endocrinology, but we'll concentrate on three of them. We'll talk a little bit about some of the molecular techniques which are being brought to bear in prostate cancer, and we'll talk a little bit about the genetics of prostate cancer and the epidemiology of prostate cancer. And as many of you in the audience know, this kind of multidisciplinary research effort, this large effort, requires tremendous amounts of funding from the federal government, so-called research grants. And we've been fortunate to have accumulated a fair number of these grants, which puts us in the top group within the nation. And of course, the most important or largest of these grants, awards, is the so-called SPORE grant, which are special programs of research excellence in prostate cancer designated by the National Cancer Institute to several groups around the country. Having said all this, now we need to move on with the program. And the program will entail 4 presentations. First, on epidemiology and genetics by Dr. Stanford, on molecular predictors of outcome by Dr. Nelson, on intermittent androgen suppression therapy by Dr. Agano, and then a little bit about the newer chemotherapy approaches by Dr. Montgomery. And so with that introduction, it's my pleasure to introduce Dr. Janet Sanford, who is Professor of Public Health both at the Fred Hutch Cancer Research Center and at the University of Washington. Dr. Stanford.
Thank you. Today I'm going to review a little bit about the background and epidemiology of prostate cancer and mention some of our work in the genetics of trying to understand this complex and common disease that is a major public health problem for men in this country. Prostate cancer alone accounts for about 1/3 of all new cancers diagnosed in men each year. Over 230,000 men will face this diagnosis this year alone. In addition, it accounts for about 10% of all prostate cancer deaths in men in this country. This slide shows the age-adjusted incidence of prostate cancer in men over age 65 and temporal trends and patterns after the introduction of the PSA blood test for the early detection of prostate cancer. And what you see is a large increase in incidence of this disease that started in the late 1980s, peaked in the early 1990s, and is now fairly stabilized in both black and white men older than age 65. However, in the post-PSA era in men under age 65, we're continuing to see on an annual basis an increase in incidence of this disease. However, the good news is that when we look at mortality from prostate cancer, as incidence has increased, we've seen a significant decline in mortality from this disease, and so fewer men each year now are dying from prostate cancer. When we look at risk factors or causes that contribute to prostate cancer occurrence in the population, we know that age is one of the strongest risk factors. Prostate cancer increases dramatically as men age. Family history is also an important risk factor, and any man who has a close relative, a brother, father, or son that's been diagnosed with the disease has at least a 2- to 3-fold higher risk of being diagnosed with clinical prostate cancer. African American men in this country have the highest incidence of this disease in the world, whereas Asian men in Asia, Chinese, Japanese, have the lowest incidence of prostate cancer in the world. We don't know what factors contribute to fully explaining these international and racial differences in disease incidence as well as mortality, but there are a number of factors listed on this slide that have been examined, and I don't have time to go through all of these, but just to mention that we know that androgens are important in prostate cancer etiology. We don't exactly understand how androgens play their role, but we know that they're important. We know that dietary factors are important. High fat, high red meat intake, high calorie intake have all been linked to a higher risk of developing prostate cancer, whereas if you eat your vegetables, we know that your risk is decreased by about 50%, and there are ongoing studies of these factors. In addition, one of our recent studies highlighted the association between cigarette smoking, high duration, long-term cigarette smoking, and more advanced prostate cancer development. We also have other studies in the field right now looking at a number of commonly used medications such as aspirin and other non-steroidal anti-inflammatory medications and how these factors may be associated with prostate cancer and in fact may reduce the risk of prostate cancer. And all these studies are ongoing here at the University of Washington and the Fred Hutchinson Cancer Research Center. Now we know that prostate cancer is a complex disease, and in complex diseases there's more than one factor contributing to the occurrence of this disease, and this includes both environmental factors that you just saw on the previous slide as well as genetic factors. And when we talk about genetic factors, we're talking both about genetic variants or normal variants within genes that everyone has, such as the gene for eye color, where some people carry the gene that codes for blue eyes, some people carry the gene that codes for brown eyes. Those are both normal variants, if you will. But there are certain variants in genes and pathways that are important to prostate cancer biology, where a particular variant may in fact interact with a particular environmental exposure to increase a man's risk of disease. And so we think that interplay between your genetic background and what you eat, drink, smoke may come together to increase incidence of prostate cancer. We're also interested in genetic mutations or heritable mutations, alterations in the DNA code that some men are born with that puts them at a much higher risk of developing prostate cancer during their lifetime. And we have studies ongoing of both these types of genetic factors. But first I'd like to point out that when you think about the component of prostate cancer that might be attributed to genetic versus environmental influences, on this slide are summarized those estimates for the 3 major solid tumors that we deal with. And what you can see highlighted in blue is that for prostate cancer, 42% of the disease is thought to be attributable to genetic factors. And this would include both the heritable mutations that some men are born with, as well as the genetic variants. Whereas about 58% of prostate cancer is estimated to be due to environmental factors. And we know that there's some interplay, in fact, probably a fair amount of interplay between the genetic and environmental factors. But as you can see, genetics is thought to account for a larger proportion of prostate cancer than has been attributed to breast and colorectal cancer. Now, when we think about hereditary prostate cancer, we know that it accounts for only about 5 to 10% of prostate cancer in the general population. And these are families where they're very dense with many prostate cancer cases in close relatives, and the cancers that are diagnosed in these families tend to be diagnosed at a younger age. We can also subdivide prostate cancer into what we call familial disease, and these are families that don't have as many cases as what we see in the hereditary pattern of the disease. And we think that familial disease accounts for about 10 to 20% of all prostate cancer in the general population. Sporadic prostate cancer accounts for the largest proportion. 75–80% of all men that come to clinical diagnosis with this disease will report no family history of the disease in a first-degree relative. And we think that some of the same genetic and environmental factors may influence risk of all 3 of these subtypes of disease, and we're trying to understand, initially doing some of our work on the hereditary disease because it's a little bit easier to study and find the cases, but we think those genes and pathways may in fact play an important role in the other subtypes of prostate cancer. And just to give you a flavor for the type of family that we're working with, when we talk about hereditary prostate cancer on this slide, you can see on the top pedigree or family tree. This is a family with 3 generations of men that have prostate cancer. You can see that in the middle generation, 6 out of 8 of those brothers have come to clinical diagnosis with the disease. And then in the lower generation, there's a 51-year-old and a 40-year-old. The dark boxes represent men who've been diagnosed with prostate cancer. And so these are very highly affected prostate cancer families that we're working with. We do have a multidisciplinary research project, a very large study called PROGRESS, the prostate cancer genetic research study that we've been working on since the mid-1990s. We've collected information from 271 families from all over North America and family members that are participating, and provided medical history information, DNA samples for us to do genotyping, and we've just recently completed a full genomic scan across all chromosomes looking for markers that may be linked to high-risk hereditary prostate disease. We've analyzed some of this data and been involved in the discovery of a region on chromosome 1 at 1p36 that appears to be important in causing hereditary prostate cancer in families that also have a history of primary brain cancer. In addition, we've localized 2 regions on chromosome 6 and chromosome 8 where we're doing follow-up studies to see if we can focus more tightly on regions that may be linked to hereditary disease. And then most recently, we've identified a locus, very strong evidence for a locus on chromosome 7q in a subset of our hereditary prostate cancer families that have a Jewish heritage. And this slide just summarizes where we are in the field in terms of trying to find the genes that cause the hereditary form of prostate cancer. There are 9 different regions or locations, if you will, on chromosomes that have been linked to high-risk hereditary disease. And highlighted in blue are the 2 regions that our group here at the university and Fred Hutchinson and the Institute for Systems Biology have been instrumental in finding, and we're doing further work. These locations tell us where on the chromosome we are, but that's like being in a big city, and now we're trying to narrow down those regions to find the genes that might be responsible. In addition to hereditary genes that play a role in prostate cancer, we're also interested in pathways that we know are important in prostate cancer biology and in normal prostate biology, and this is the androgen pathway, and there are multiple genes, 4 of them here. I'll just point out the SRD5A2 gene that's of great interest in terms of having normal variants within that gene that alter enzyme activity, and it's that enzyme that converts testosterone from the bloodstream into its very potent androgen in the prostate, DHT. And some men have a variant in this gene that would increase the activity of this enzyme that would then result ultimately in higher androgen exposure in the prostate. And these are the kinds of things we're looking at in terms of normal variants that may increase a man's risk. Listed on this slide are a large and growing list of genes that are of interest because they're in pathways that are probably going to play an important role in prostate cancer biology. These are fairly common variants. More than 2% in the general population of men would carry a variant that would alter the genetic product of these genes to make these enzymes either more or less active that would then potentially play an important role in prostate cancer biology. So where are we in terms of our research directions? We've got a number of studies focusing on both the underlying genetic and environmental factors that cause prostate cancer. More importantly for prostate cancer, probably than any of the other solid tumors, is we need to find out what factors cause these small prostate cancers that many men harbor in their prostates to progress to clinically important disease that's biologically relevant. And then lastly, what we're trying to understand is what causes some of these prostate cancers to progress to their lethal androgen-independent phenotype and result in prostate cancer mortality. Now, once we can understand the causes and the pathways that operate in prostate cancer etiology, then we can develop more innovative approaches to prostate cancer prevention, because obviously prevention is better than cure in some ways, and if we can prevent this disease from occurring in the first place, we'll be farther down the road of conquering prostate cancer. And this slide just lists 4 of a growing list of potentially promising approaches to prostate cancer prevention, including lowering androgen exposure in the prostate. There's a large trial right now of selenium and vitamin E that may work to prevent prostate cancer, and that trial is in the field. We think that it's prudent to eat a low-fat, high-plant food diet, because diet contains many factors that have been shown in prostate cancer cell lines and model systems to reduce risk of prostate tumors. And then, as I mentioned earlier, there are a number of commonly used medications that we're looking at that may play an important role in our repertoire of approaches to prevent this disease. And now I'd like to introduce Dr. Pete Nelson, who's a medical oncologist from the University of Washington, and Fred Hutchinson. Thank you.
One of the major dilemmas facing patients with prostate cancer and the clinicians that are treating them is the fact that it's very difficult to predict an outcome or a prognosis for any given patient's disease. While this is important for most cancers that we deal with, it's particularly important for prostate cancer because of the dramatic heterogeneity that's present in these outcomes. We know from epidemiological studies that many men with cancerous cells in the prostate, their health will never be impacted by the disease, and many of those men should probably never undergo treatment. However, there's another subset of men with prostate cancer whose lives will be impacted by the disease but could be cured by a local therapy. This could be radical prostatectomy or radiation therapy. There's another class of patients whose cancer is so aggressive that local therapy alone probably would not be curative, and they would need something in addition to that therapy. So trying to provide some prognostic information for the patients and the clinicians is very essential in order to provide for the correct form of therapy that would have the least amount of morbidity. There are a number of ways currently that clinicians and patients attempt to predict how their given cancer will progress. One of these methods is using a histology of basically what that cancer looks like under the microscope to the pathologist. A second is the clinical stage, that is, when the clinician examines the patient, how extensive does the disease appear. A third are measuring protein levels, either in the blood or in the tissue. An example of this is the serum PSA, or prostate-specific antigen. A number of these factors have been combined. Instead of using an individual determinant, such as the cancer grade, many of these factors have been combined together into different tables or nomograms that provide some evidence of outcome. Perhaps at this point, the best indicator of prognosis is what the cancer looks like under the microscope. That is, the grade of the cancer. In prostate cancer, this grading system has been developed by a pathologist by the name of Gleason, and it is called the Gleason grade of prostate cancer. The grading system is a bit different than other cancers in the sense that we're assessing the heterogeneity of the cancer and assigning not just one score or determinant to the cancer, but several scores. In this case, we're assigning the most predominant area a score between 1 and 5, and the next most predominant area a score between 1 and 5. These scores are added together, and you get a grading scale between 2 and 10, 2 being fairly lowly aggressive, 10 being very aggressive. This is a bit of a complex slide, but it's important because it illustrates the point of how a grading system can be used to determine outcome. I'll draw your attention to the panel in the lower left corner. All of these panels within this slide basically show similar types of information. On the x-axis, or the bottom, we have the number of years after diagnosis. On the vertical axis, the y-axis, in white, we have the percentage of those men after diagnosis that are still alive, and the gray area, the dark area, indicates the percentage of men that have died due to the prostate cancer. Vertically here, we have the boxes divided up by Gleason grade. So you can see that a very low-grade cancer between 2 and 4, the chances of dying of prostate cancer is very, very low, probably less than 5% within 15 years after diagnosis. However, the high-grade cancer, there's a very high likelihood that a given individual will die of their prostate cancer. I'll direct your attention to this Gleason grade 7 box, and we can see that we can take all comers and find that within 15 years, approximately 60% of those men will die of their prostate cancer. But those types of numbers are not very informative for the individual patient trying to make a decision regarding treatment. You can tell the patient you have a 60% chance or a 40% chance, and for the individual patient, for the clinician, that's not very satisfying. Our objectives are to find better discriminants, better predictors of these outcomes that can be more individualized or targeted on a patient basis. You can think of predictors as being fingerprints is our objective, a fingerprint being a very accurate predictor of how a cancer will behave. In our case, we're studying molecular predictors, that is, the genetics of these individual tumor samples. Now, these molecular profiles or molecular predictors, again, we think of as fingerprints. The underlying principle here is that the phenotype or the potential of a given cancer cell to be invasive into surrounding tissues, to resist or survive chemotherapy or radiation therapy, or to metastasize and thrive in distant sites is really dictated by what portion of the genome is used by that cancer cell. That portion of the genome that is used it's called the expressed portion of the genome. We have two objectives for determining gene expression profiles or gene expression fingerprints. The first are to identify individual changes, specific genes that could be used for us to understand the biology of the tumor, also to be used as potential diagnostic markers such as PSA, or third, to be used as specific targets for therapy to direct an immune response against, for example. The second objective is, instead of looking at individual genes, we'll use the profile in total to see if this fingerprint would be more predictive of outcome as opposed to an individual gene. The methods that we're using have been spawned by the Human Genome Project and allow us to comprehensively look at those genes that are used or expressed in any given tissue. The approach that we're primarily using is an approach called a cDNA microarray or a DNA microarray. The technique involves spotting individual genes of interest onto some type of solid support, in this case, a glass microscope slide. We can put down tens of thousands of individual genes in specific spatial locations on these microscope slides. The strategy then is to capture the expressed information from a normal tissue or a cancerous tissue. That expressed information is the messenger RNA. We extract the messenger RNA, in this case from normal, in this case from tumor. We can label it with different fluorescent reporters that distinguish the normal from the tumor messages. In this case, we've labeled the tumor with red and the normal tissue with green. We then simultaneously put these expressed information units onto the microarray. Each of these individual dots represents a different gene. A gene expressed highly in normal will show as green. A gene highly expressed in cancer will show as red. A gene expressed roughly equivalently between normal and cancer will show as yellow. So simultaneously we can access the expression information for normal tissue and tumor tissue. The goal here then is to, for any given patient, we acquire tumor tissue either at a biopsy or a radical prostatectomy. We assess the molecular fingerprint or the profile and determine that this profile indicates how that cancer will behave. In this case, a low relapse risk. In this case, an intermediate relapse risk. In this case, a very high risk for relapse. This can then dictate what type of intervention that patient should receive, whether it's simply observation, some type of local therapy, or for very high-risk disease, something in addition to that local therapy, such as immunotherapy. Importantly, prostate cancers are quite heterogeneous. We're not dealing with a well-circumscribed tumor sample. Many times these tumor cells are mixed in very tightly with the normal tissues. So the complexity of this tissue will impact what our expression profile actually look like. So our goal has been to focus on cell type specific analyses. This slide brings home the point. The background that you can see is the histology for a biopsy taken from a man with prostate cancer. We have two small regions of cancer intermixed with many normal benign glands. The representation of the cell types within this very complex tissue show that the cancer cells represent only about 15%, 10 to 15% of all of the cells within this sample. So our focus has been to specifically interrogate the cancer cell within this complex tissue, the cell type specific analysis. So our objective has been to go back to different grades of cancer, the Gleason pattern 3s, 4s, and 5s, and to microdissect the individual cells of interest for these types of fingerprint profiles. The tool that we use to do this involves a technique called laser-assisted or laser capture microdissection. There's a microscope that can be used to focus a laser on very specific areas of the tissue of interest. In this case, we're capturing a set of benign glands. The laser excites this tissue, which can be captured onto a thin thermoplastic film, and here we've specifically captured the cells of interest that we're planning on looking at the expression profile of. The microarray that we've developed stems from several years of work that we have undertaken to define every gene that's expressed within prostate tissue. This information has been assembled into a database called the Prostate Expression Information Database that's available on the World Wide Web. We've taken a subset of these expressed genes and constructed customized microarrays. This slide gives you the results of an experiment looking at expression differences between cancer cases and normal tissue. Here we've assembled about 23 cases. Each case is represented vertically. We also have individual genes present here on the y-axis. Red indicates a gene that's highly expressed in cancer tissue relative to normal. Green indicates an area where the gene is highly expressed in normal tissue relative to the cancer. Stemming from this work, we can then confirm these types of results. This is immunohistochemistry for a specific gene that we identified to be downregulated in cancer based on the microarray studies. Here we can see, based on immunohistochemistry, that the protein is highly expressed in the normal gland and very lowly expressed in the cancer gland. This gene is involved in lipid metabolism, and lipid metabolism is an important aspect of prostate cancer, as demonstrated as an important risk factor for prostate cancer, as described by Dr. Stanford previously. This is another example of a microarray study looking at different Gleason grades. Here, arrayed at the top of the slide, are cancer grades oriented by Gleason 3, Gleason 4, and Gleason 5. We can see that a large number of genes are consistently increased in expression in all grades of prostate cancer, and a large number of genes shown in green are downregulated in all of these grades of prostate cancer. But we also have distinct patterns that are capable of distinguishing Gleason pattern 3s, Gleason pattern 4s, and Gleason pattern 5s. This now gives us a molecular or biochemical explanation for why a given Gleason grade cancer that's high grade behaves aggressively versus a low grade cancer that behaves in a fairly benign fashion. So to summarize, what we are now capable of doing is determining that portion of the genome that is used or expressed in a normal cell and a cancer cell in a very comprehensive fashion to produce what we are calling this fingerprint. If we do comparative studies of fingerprints between normal cells and cancer cells, or lowly aggressive cancer cells and highly aggressive cancer cells, we can start to determine the molecular differences between these types of cancers. Ongoing studies will utilize these expression fingerprints in attempts to predict outcome both without therapies and outcomes due to specific interventions. This is an example of such an intervention that we currently have ongoing at the University of Washington and the Fred Hutchinson Cancer Research Center. We have a clinical trial where patients are entered at the time of their diagnosis. At that point, they have a biopsy where we assess an expression profile by microarray. They then undergo treatment. In this case, the treatment is two types of chemotherapy, mitoxantrone and Taxotere. You'll hear more about these chemotherapeutic drugs later in the presentation by Dr. Montgomery. These patients are treated prior to surgery for 4 months with this chemotherapy. They then undergo radical prostatectomy, and we then assess the gene expression profile after that therapy to determine if the molecular fingerprint is predictive of those patients that did or did not respond to that particular therapy. The challenges are many to use these types of fingerprints to predict outcome. Certainly we know there's quite a dramatic genetic heterogeneity or genetic background in these individuals. There's also environmental heterogeneity. The patients are exposed to different diets and different other environmental influences. We also know that there are large sample sizes, large number of patients that need to be enrolled in these types of studies to statistically determine their outcome, and the patients need to be followed for many years after their initial treatment. There are also a number of host factors that we're currently not assessing, such as individual immune response or hormonal status. Future studies will focus on these aspects and correlate those with the tumor expression profile as well. So that concludes this aspect of the presentation. I'll next introduce Dr. Celestia Hagano, who's an associate professor of medical oncology at the University of Washington, and she'll talk about androgen therapy.
In the following presentation, I'm going to give a review of our clinical research program using intermittent androgen suppression to treat men with prostate cancer. We've known for many decades that prostate cancer is an androgen-dependent tumor in that it grows in the presence of testosterone and initially regresses in response to androgen deprivation, but eventually it will grow even when the testosterone levels are low. It's this androgen-independent growth that eventually causes death in prostate cancer patients. The Shionogi carcinoma line can mimic the behavior of prostate cancer in men. When implanted into an intact male mouse, the tumor will grow under the influence of testosterone, and after castration, it will regress for a while until eventually this androgen-independent growth will take over. The tumor will grow and cause death in the mouse. If, however, the same tumor cells are re-implanted and re-exposed to testosterone through serial implantations into intact male mice, the duration of the sensitivity to androgen deprivation will be prolonged through 5 castrations prior to the development of androgen-independent growth. This preclinical model that was described actually in the late 1980s by our colleagues Nick Brukowski et al. In Vancouver, British Columbia, raised the issue of whether lowering the testosterone levels in a similar manner in an intermittent fashion might delay time to androgen independence in patients with prostate cancer and perhaps delay their death. In 1993, the concept of re-exposing patients to testosterone was highly controversial and many considered the approach foolish at best and dangerous at worst. Nonetheless, in 1993, based on some early clinical data from our colleagues in Canada, we decided to initiate a pilot study to evaluate the safety and feasibility of this approach. We allowed any prostate cancer patients who had never been treated with hormonal therapy to enter this pilot study. Patients were treated with 9 months of androgen deprivation consisting of Lupron and flutamide. Treatment was then discontinued, and the PSA and testosterone levels were followed monthly until a PSA reached a threshold, at which time the hormonal therapy was restarted for another 9 months and cycled accordingly until androgen independence occurred. In 1996, we reported the results of our pilot study demonstrated that intermittent therapy was in fact feasible and safe. No patients suffered any dangerous regrowth of their tumor when the testosterone levels were elevated during the off-treatment period. We also noted that patients felt better during the off-treatment period, but this was not formally evaluated with quality of life questionnaires. We also observed that patients seemed to gain weight on hormonal therapy, a finding that hadn't been noted previously, that they reported fatigue or lack of initiative while on hormonal therapy, but they felt this go away off of hormonal therapy. And occasionally some of the spouses would report or question whether their husbands had decreased mental abilities due to the hormonal treatment. We began to question whether or not there were other deleterious effects of androgen deprivation that had perhaps been attributed in the past to the man's prostate cancer, particularly since this was usually used for men with metastatic disease. But we were wondering, were some of the side effects actually due to the treatment itself rather than the cancer? At this point, we recognized that we would not be able, as a single institution, to answer the question of whether intermittent therapy versus continuous therapy would delay time to androgen independence. This would be the subject for large, randomized clinical trials involving thousands of patients. Instead, we decided to focus on a new population of prostate cancer patients, men with so-called biochemical relapse. These men were a member of a new population of patients that was primarily noted because of the availability of PSA. They had undergone primary treatment with either surgery or radiation, but months or years later had a rise in PSA blood level. Despite this rise in PSA blood level, there was no evidence of metastatic disease, and therefore these men were asymptomatic. This meant they were very good subjects to evaluate some of the side effects that we were looking at, such as quality of life, fatigue, and so on. In addition, we realized that these men with this biochemical relapse would live for many years compared to men with metastatic disease. Therefore, they had the most potential to suffer the long-term effects of androgen suppression, both on the body and potentially on the mind. So we felt it was important to document these toxicities and to devise appropriate intervention strategies to help them have a better quality of life. So in 1997, we initiated a formal study looking at this population of men with biochemical relapse. We looked at quality of life with formal questionnaires and looked at something that was very concrete and quantitative, looking at bone mineral density by DEXA scan. In 1999, we also began to look at cognitive function. We presented our bone mineral density data at the American Society of Clinical Oncology in 1999. This was actually the first prospective bone mineral density data that was collected on patients with prostate cancer being treated with androgen deprivation. Our presentation was chosen for press release in order to highlight the potential downside of androgen suppression on men with this early stage of prostate cancer relapse. In a quick summary, our results showed that hormonal therapy did cause very significant loss of bone mineral density after only 9 months. The normal expected loss of bone mineral density is 0.5% to 1% per year, But in our study, patients lost 2 to 4% of their bone density in only 9 months. This is actually greater than the loss that is experienced by menopausal women. During the off-treatment period, when patients were not on the hormonal therapy, there was a decrease in the loss. In other words, actually there was no change in bone mineral density during that time. So it appeared at least that this intermittent approach delayed the loss of bone mineral density due to androgen suppression. Well, what about the cognitive functioning aspects? Is this affected by a low testosterone state? Well, we know in elderly hypogonadal men that specific areas of function do improve when you replete them with testosterone. So in order to answer this question, we collaborated with Dr. Monique Charrier in the Department of Psychiatry. She specializes in geriatric affairs and studies cognitive function in such elderly men. So she designed a trial to look at cognitive function serially in men treated with intermittent therapy. I'm just going to show you a couple of the tests that we put our patients through. This is one test that is a grid on a floor that patients follow the red line and must learn this route both without and with some kind of landmark. The red line is then removed from this grid and the patients need to renegotiate the maze. A measure of attention, just as an example, would be to ask the patient to read the colors and then to only read the color of the word. And if you try this, it can be quite challenging. A third task, again by example, is that the patient is asked to look at this index block shape and to find the matching rotated shape amongst these 4 options. Now, what we found was published in the fall of 2003 in 19 patients undergoing intermittent suppression, that this last skill that I showed you called spatial rotation, that particular skill was impaired. And in fact, that was expected based on what we see in elderly hypogonadal men. But interestingly, there actually was no change in verbal or spatial memory, so-called executive functioning or language skills. Clearly, this requires further study and confirmation, but it gives us some handle for the first time about whether or not this therapy does affect men treated with hormonal suppression. Now, getting back to the issue of whether or not androgen independence can be delayed with intermittent therapy, there are 2 intergroup trials going on. They are including 1,000 or more patients, and we will have to wait for the results of these trials to find out the answer to that question. Where are we going in the future with this research? Well, first of all, we are very invested in continuing to develop our work in cognitive functioning. We have a Department of Defense grant to look at functional imaging of the brain with both PET and MRI scans. We also want to look at interventions. What can be done to affect some of these adverse effects, such as bone mineral density, weight gain, lipid abnormalities, and we are looking at exercise as an intervention to see if we can minimize these effects. And finally, we are adding novel agents during this off-treatment period to see if we can prolong the time off of hormonal therapy. Patients should theoretically have a better quality of life during that time. But as important, perhaps, is also prolonging time to androgen independence. In this model, we have already looked at the drug thalidomide, which has anti-angiogenic effects, exasulin, which is a pro-apoptotic drug, and we are currently proposing to study atrasentan or some other novel agents during this off-treatment period to see if we can accomplish that end. So in conclusion, the intermittent androgen suppression has provided a very good model system to study the effects of androgen deprivation on men treated for prostate cancer. Our current investigations are studying ways to diminish the adverse effects of hormonal therapy and to lengthen the time off of therapy and delay time to androgen-independent death. And we are actively recruiting men for these and many of our other trials in prostate cancer. Thank you very much. The next speaker is Dr. Bruce Montgomery, my colleague in medical oncology from Veterans Administration Hospital and University of Washington.
These first two grand rounds in the urology division have very clearly illustrated both the challenges that patients with prostate cancer face and the progress that we've made in the treatment of patients with localized disease, and, as Dr. Higano has just discussed, the therapeutic options which exist for patients with metastatic or advanced disease, which is androgen sensitive. Once patients develop what is called androgen-independent disease, for many years it's been felt that perhaps we really didn't have effective therapy available for these patients. But what I want to talk to you about this morning is data that has accumulated over the last several years, which has clearly demonstrated that we have therapy available, systemic chemotherapy, which has benefits with regards to palliation and benefits with regards to duration of survival for patients who have advanced disease. So, as Dr. Higano has discussed, androgen deprivation, which is our primary treatment for systemically advanced disease, is very effective. 80 to 90% of patients will have a response, either PSA or symptomatically. And this is obviously something that, in general, continues for a number of years. Unfortunately, the situation is that unless this therapy is followed up with potentially curative radiation or surgery, androgen deprivation by itself is not a curative intervention. Ultimately, prostate cancer will find a way to grow, even in the presence of very low systemic levels of androgen. The mechanisms by which this actually occurs are something that I'll discuss in a minute, but I think that one of the things that we oftentimes go through in the clinic is what are called secondary hormonal manipulations. These are things that we do to try to return the prostate cancer to an androgen-dependent state. And although we can certainly have responses in these patients, the benefits to patients in terms of survival are somewhat unclear. I think it's important that we discuss the potential mechanisms of androgen independence, because this is an area that is really one of the most important questions, both in the laboratory and in the clinic, that investigators at the University of Washington and at the Hutchinson Research Cancer Center are looking at, because this, as Dr. Higano discussed, is how patients ultimately come to have complications of their disease. A number of investigators would suggest that in every clinically apparent prostate cancer, there are very small numbers of androgen-independent clones. And when you use androgen deprivation, in fact, you remove essentially all of the sensitive cells, but these small number of androgen-independent cells will grow out over time and make up the bulk of patients' malignancy. If this is the case, we should be focusing our efforts on using therapies that actually will attack androgen-independent clones much earlier in the course of disease for patients. So, for example, using chemotherapy as adjuvant therapy early in the course of disease for patients who are at high risk for relapse. Other investigators would suggest that, in fact, very low levels of androgen or other hormones continue to interact with the androgen receptor in prostate cancer, and that this is enough to drive proliferation of the tumor. If that is the case, again, we should be actually focusing our efforts on improving the ability to antagonize the interaction between androgen and its receptor. Yet other data suggest that, in fact, androgen receptor by itself, simply by overexpression, continues to signal. And in fact, our efforts should be focused on removing the androgen receptor entirely, or by inhibiting downstream signal transduction at the level of the receptor. And finally, there is actually very good evidence that suggests that the insulin-like growth factor receptor and the epidermal growth factor receptor play an important role in the transition from androgen-dependent to androgen-independent disease. And with the new agents that are becoming available for us in clinical research studies, we should be using those agents to actually answer the question of whether this is the way in which we should interfere with the transition from androgen-independent to androgen-independent disease. Now, these are principally research questions that we're still asking in the laboratory. When a patient presents in the clinic with the problem of androgen-independent disease, there are really two questions that both the patient and the provider have to ask. First, is this therapy, the systemic chemotherapy that we are usually in the situation of offering, going to benefit the patient, that is, improve quality of life, or actually degrade quality of life? And things that factor into that equation are, first, if the patient has symptoms to palliate. Secondly, whether they are at risk for complications in the relatively near future. And third, whether the patient has other medical illnesses that might make the toxicities of therapy unacceptable. Secondly, and certainly no less important, is the question of whether this therapy can improve survival for the patient. And so I think that when we're talking about this situation with a patient in clinic, we're talking mostly about these agents which are active against androgen-independent prostate cancer. These drugs fall into two general groups. First, what are called microtubule active agents. These are the drugs that are perhaps the most active agents that we have available for the treatment of prostate cancer. These drugs modulate the dissolution and the stabilization of microtubules in the cytoskeleton in prostate cancer cells and the mitotic spindle, which is a very important component of the cell cycle. So these drugs include the taxanes, docetaxel and paclitaxel, vinorelbine, which actually blocks the formation of microtubules, and estramustine, which interacts with microtubule-associated proteins and in that way changes stability of microtubules. Other drugs which certainly have activity include mitoxantrone, carboplatin, and etoposide. The standard of care for patients, which has come to general use over the last several years, was based on the palliative benefits of mitoxantrone-based regimens. Two large studies carried out by Dr. Tanek and Kantoff demonstrated that the use of mitoxantrone carried with it significant palliative benefits with regards to quality of life and pain control. Unfortunately, these improvements in overall quality of life were not accompanied by changes in survival. But these regimens were very well tolerated, and as a result, this became the standard of care based on palliative benefits to patients. And this remains a viable treatment regimen because it's very well tolerated and clearly does benefit a number of patients with androgen-independent disease. I'm not going to review all the studies that underlie the background for these two studies that I'm going to discuss in a minute, but data from our institution and other institutions clearly indicated that the taxanes, docetaxel and paclitaxel, had activity in androgen-independent disease and were perhaps the most active agents against this disease. So based on these studies, two large randomized studies, one of which we participated in, were carried out. The first was called the Southwest Oncology Group Study 9916, which randomized patients to the drugs mitoxantrone and prednisone versus the use of the drug docetaxel and estramustine on an every 21-day schedule. The second study, referred to as TAX 327, randomized patients to the standard of care, mitoxantrone and prednisone, versus two regimens of docetaxel given on a weekly or an every 3-week basis. So these studies were actually discussed at the American Society of Clinical Oncology meeting this year, and the bottom line is that both of these studies were positive with regards to palliative benefits and survival benefits for patients with advanced disease. So let's look at the details. In the Southwest Oncology Group study, which we participated in, the median time to progression for patients treated with docetaxel-based regimens was actually doubled compared to the use of the previous standard of care. Similarly, the improvement in median survival for patients receiving docetaxel was roughly 2 to 3 months, which represents a 20 to 25% improvement in overall survival for these patients. So this was considered a very significant finding. In the second study, the TAX 327, the use of docetaxel and prednisone on an every 3-week basis was again accompanied by an improvement in overall survival of somewhere between 2 and 3 months compared to the use of mitoxantrone and prednisone. So these two large randomized studies clearly demonstrated benefits with regards to overall survival for patients treated with these drugs. When we look at more detailed analysis of the Southwest Oncology Group study, there was roughly a doubling of the PSA response in patients who received the docetaxel regimens, and there was an increase in overall toxicity, which primarily was related to gastrointestinal and cardiac toxicity, which we think was mostly a function of the use of the estramustine in these regimens. In the TAX 327 study, again, there was a benefit in overall survival, primarily in the every 3-week regimen, and pain responses were also improved in patients who received docetaxel. There was also a very small increase overall in grade 3 or 4 toxicity, which is the kind of toxicity that impacts on patients' quality of life. But it was not as high as in the Southwest Oncology Group study, and again, this suggests perhaps that the estramustine may be playing a role there. So I think that the bottom line is that this is good news. We now have therapy that actually provides both palliative and survival benefits for patients with advanced prostate cancer. The better news is that this is really just the first step in improving therapy for patients with this disease. I think it's imperative that we continue to try to build on these results in order to achieve those ends. So at the University of Washington and at the Cancer Care Alliance, we're taking the approach of trying to combine docetaxel with other agents which might improve the efficacy while maintaining a relatively low level of toxicity for patients with this disease. And we're also taking the approach of trying to attack the disease from other standpoints. So for example, immunologically, using vaccines and monoclonal antibodies, and also taking advantage of the new molecular targeting agents that are out there and available for clinical research studies. So with that, I will return the podium to Dr. Lang for a summary of the discussion today.
Well, this now ends our series, our two-part series on prostate cancer. And I hope you in the audience and those in our TV audience, whether they be clinicians who deal in prostate cancer or in other diseases, medical oncologists or surgeons or radiotherapists, or whether they're just people who are interested in prostate cancer because they may have it or some of their relatives may have it, that you've learned something from these presentations. And I think more importantly, that you have caught some of the excitement that now exists in prostate cancer. And that's best represented on this slide, somewhat complicated slide, and that we and many other centers of excellence around the country are combining not only basic research, but research in clinical aspects of prostate cancer and working together to do nothing less than actually curing prostate cancer. And I think that this effort would not be possible without the availability here and at other places of clinicians who are expert and concentrate on treating prostate cancer, but also have a familiarity, if not an activity, in research, including basic research into the disease. And also the willingness of many other people, be they basic scientists, epidemiologists, patient care advocates, alternative medicine experts, nurses, people into quality of life, all working together for this common dream. And I do believe that the dream is doable. I tell my residents and others, maybe almost too much, that I was there when testis tumor was a lethal disease and most of these young men died. And now we have Lance Armstrong, the book that's not about the bike, and we have the expectation among most patients that they will be cured from this once lethal disease. And I do believe that this will happen in prostate cancer. I think it will happen in my active career life. And I do hope that members of our team, some of which you've seen today and at the other session, will be involved in that accomplishment. Thank you again for coming and for your attention.